Okay, I think we'll get started. So good morning, welcome everyone. Thank you for joining us for our final Grand Rounds lecture of the season. We will, after this Grand Rounds, we will take a break for August, and then we will resume again on September 1st. And our first speaker for the next academic year will be Dr. Dilip Jest from the University of California at San Diego. And Dr. Jest will be presenting on loneliness and isolation versus wisdom and compassion from biology to intervention. Our speaker today is Dr. Chana Sacks, who is joining us from the Massachusetts General Hospital and will be presenting on confronting gun violence in America, the medical community's role in preventing firearm-related violence. Dr. Sacks is a general internist. Oops. Sorry about that. Dr. Sacks is a general internist in the Department of Medicine at the Massachusetts General Hospital, an instructor in medicine at Harvard Medical School, and the co-director of the MGH Center for Gun Violence Prevention. Dr. Sacks attended the University of Chicago School of Medicine and completed her residency and then chief residency in internal medicine at MGH. Dr. Sacks then completed a research fellowship focused on health policy and health economics at the Brigham, while completing her MPH at the Harvard School of Public Health. In 2012, Dr. Sacks' cousin, 7-year-old Daniel, was murdered at Sandy Hook Elementary School. Dr. Sacks has since focused her career on developing and implementing a public health approach to address gun violence in Boston and across the country. Dr. Sacks' research focuses on the physical and mental health outcomes associated with firearm-related injuries and suicide prevention, particularly focused on older adults. She's also the images editor at the New England Journal of Medicine. So it's a real pleasure and treat to welcome Dr. Sacks. And with that, I will turn it over to you for your presentation.
Dr. Posner, thanks so much. I didn't know it was the last Grand Rounds of the year. Congratulations, everybody, you made it. So thanks so much for having me as an internist. It's a lot of fun and to be among the Department of Psychiatry here. And so I'm really grateful for the opportunity and look forward to this conversation. So I'll jump right in just saying I have no financial disclosures. I do always note that conversations about gun violence and suicide can be deeply personal, and sometimes unpredictably emotional or affecting for people. And I just want to acknowledge that if the 70 people here on this webinar today, if we're a random group around this country, then a lot of us have been affected by gun violence in some way. And I just want to start out by acknowledging that whenever I give a talk in person, I always invite people to absolutely feel free to step out for a minute if they need to. This is a webinar, I can't even see you, so I wouldn't even notice if you did. So really do take that opportunity if that makes sense for you at any point during our conversation today. I think the reason that I was invited to talk in this forum and at this maybe moment in time is that I think it's really hard if you're living in this country. It's hard not to think about gun violence. And no matter what day it is that we're having this conversation or talking about it, you'll find headlines on the news that look just like this. This is just a CNN screenshot from this Sunday talking about multiple shootings over the weekend in Seattle that left 3 people dead and 5 people injured. I think things like this are so common that many of us may have even missed that story when that just happened, that multiple shootings in one city around the country is just sort of a normal weekend. So these are normal Sunday headlines, quote unquote. And then there are other headlines that come up, things like we're grappling with in Boston that I think almost every other city around the country is looking back at their data over the last year and thinking about the last 18 months and what we've been experiencing in the midst of COVID. And what we've seen here in Boston is that shootings are up about 30% during 2020. And headlines are in all sorts of forms. Sometimes the headlines tell a narrative. Sometimes that's totally connected to reality. Sometimes it isn't. Certainly for those of us watching ranked choice voting and how that played out, us Bostonians, we turned it down on our last election, because we were sort of watching how it unfolded in the mayor race in New York. what was just clear reading, with the New York Times being my source of reading about that election news, it was pretty clear that conversations about violence and gun violence, whether reflecting reality or the narrative that was being discussed in the media, really did seem to shape part of that election in the final week. So I think for so many different reasons that this issue, this topic, shows up in the news and in a lot of our minds on a pretty regular basis. And as it does, I think we have this fundamental question, which is what role does the medical community have in this national conversation? Are we people in this country just sort of watching these headlines? Do we know people? Have we had personal experiences? Or do we have specific role as doctors, as clinicians, as we think about how we take care of our patients? And as we do this, my goal for the discussion that we're having today is to sort of move this away from sort of a hyper-partisan and political, which is where this conversation too often lives, and really discuss what it means to bring gun violence prevention to the bedside, what it would actually look like to bring that and incorporate that into clinical care across disciplines. And when we do that, I promise I'll stay as grounded in data as I possibly can throughout this conversation, both data generated by me and others in our Center for Gun Violence Prevention here and other researchers across the country. But really, when we start and we look at the numbers, here they are, that approximately in this country, approximately 40,000 people die every year from firearm-related violence. And when you put that up, and sometimes I'm a visual person and just sort of put this up using CDC numbers, looking at the number of deaths from firearms and the number of deaths related to a ton of other medical conditions. And I think for me as an internist, when I first started looking at these numbers, what struck me is how differently we treat morbidity and mortality related to firearms from morbidity and mortality related to so many other conditions. And by that, I mean, as I went through medical school, as I went through my internal medicine training, I had lecture after conversation, after didactic, after OSCE, after session, thinking about pneumonia and liver disease, melanoma, HIV, all of those topics we talked about and learned about a ton through lectures, through thinking about the different pathways that lead to disease progression, thinking about opportunities for intervention and what those approaches look like, thinking about what it means to holistically take care of patients who have these diseases or have family members with these diseases. And I'm sure that I'm not alone in this group to say throughout all of my medical training, I had not one real conversation or lecture or anything related to thinking about violence or certainly firearm related violence. And that just the more that I started to be immersed in this field, in this space, just seemed progressively just like an inexcusable miss for the way that we approach this topic, that we're kind of guilty of making it something other than other things that affect our patients. And as clinicians, I don't think we get to choose what issues we take on. We have this obligation to take on the issues that are affecting the patients that we care for. And when we look at the numbers, no matter where we live in this country, this is a very real issue that has impacted a lot of our patients' lives, and whether we know about it or not. And I will just take a minute to say what I think the news media makes pretty clear, but I'll say it pretty explicitly, that this is an American problem, that compared with other high-income countries, you can just sort of see the rates of death from firearm-related violence across every age group are really off the charts. The blue here is the US, the orange not US, other high-income countries. And really from our littlest kids to our teenagers to young and older adults, this is really an issue across age groups where we really stand out as the outlier among nations. And as we sort of delve into this conversation, I try to be really explicit about the terms that I use. I think the narrative often in the public discourse is pretty thin and refers to gun violence as if it's sort of one thing. And that's just not the way I think about it. I think about deaths and injuries, for that matter, for firearm-related deaths being viewed as 4 different types of violence. And one is these mass shootings that really dominate the national discourse quite often. Homicides and other assaults that disproportionately affect communities of color. That's true here in Boston, there in New York, and really all across the country. There are these so-called accidental, which are referred to more as unintentional shootings, where you see those headlines where a 5-year-old finds an unlocked and loaded gun and shoots a sibling or a neighbor. And then there's suicide, which I would argue that we don't talk about much at all when it comes to firearm-related deaths. But of course, when we look at the data and the numbers, we find it's really just the opposite of how we approach this topic. that these mass shootings that not only dominate the national discourse, but really dominate some of the discussions about what should be done, which we're going to talk about more, account for far less than 1% of all deaths related to gun violence. These unintentional shootings, about 2%, homicides, about a third, and suicide, again, the least discussed form of firearm-related violence, accounts for almost 2/3 of all gun-related deaths in the US. So as we go through, we're going to go through in the order the data tell us. We're going to start with suicide. It's where I am most interested in, especially in hearing some of the feedback and reflections from this group, and we'll go from there. And the takeaway here, I think, really is that access to lethal means really matters. And I think our understanding of that and our ability to convey that fact to the public is a place that we've really been lacking. This is an issue that I'm sure is not at all new to this audience, that suicide rates have increased across the US pretty substantially. These are data from CDC looking at the delta between 1999 and 2016. And a couple of factors really strike me. One is that we see this pretty much everywhere across the US. Nevada, which is sometimes looks like the outlier there, was basically stable during this period and has a pretty high baseline rate. So I don't see that as sort of a positive outlier here. So one is I see that this increase is really pretty diffuse across the country. And then a couple other things jumped out at me from these data. And one is I was first reviewing these data years ago. And as an internist, the fact that right there, what I have circled, that more than half of people who died from suicide had no known mental health condition, really was a striking and important realization for me. And I think part of that was because when I looked through the curriculum and looked at who was being trained to either talk about lethal means counseling or think about suicide prevention, it wasn't showing up in our internal medicine curriculum. It was showing up in our psychiatry colleagues. You all were the ones leading the way. And recognizing, though, that more than half of people who were dying from suicide had no known mental health condition or diagnosis at the time of their death, really meant that if we in the medical community are leaving it all to our psychiatry colleagues, we're going to miss a lot of people. That the places that we're seeing the highest rates of increases among adolescents, we're seeing the highest baseline rates among older adults, especially older adult men. Those are people that may not be showing up in psychiatry clinics, but they are absolutely showing up in medical care. They're showing up in our emergency rooms. They're showing up in primary care. And if we're not training that larger clinician workforce to understand those risk factors, to think about lethal means counseling, to think about when conversations about firearm safety might be relevant, then we're really missing opportunities to meet our patients where they are, especially those who may need to hear from us most. And this has been shown time and time again. I don't think I'd have to convince this audience, though I do have to spend more time on this in other rooms that are less used to hearing about these data, that access to firearms is an independent risk factor for suicide. I will be very open in areas where my conclusions are outpacing the data. This isn't one of them. There's a threefold increased odds of death from suicide. There's a meta-analysis published in the Annals a few years ago, pulling 16 studies, really all showing that same thing. A threefold increased odds of death from suicide if there's access to a firearm compared to if there isn't. When we think about why that is, it may not be surprising, but I think it's really still important to consider that it really is about the means. And what we see is that poisoning, fatal overdoses, which is the most common means of attempting suicide in the United States, those are fatal in about 2% of cases. And I think we as internists, we get very used to meeting these patients on our service. Plenty of people come in intoxicated with active suicidal ideation or after a suicide attempt. When they're intoxicated, especially if some of their labs are so-called in the red, they get admitted to medicine. But by the time a day or two later, those substances are then out of their system and they've had a moment to sort of slow down. Oftentimes, by the time they meet with our psychiatry colleagues, they're no longer meet we call it up here section 12. They no longer meet inpatient criteria. We're discharging a lot of these patients oftentimes home directly from our medical services. And I think that's a critical point to remember, that it's just because we get a chance to meet those patients, that if that same patient had attempted suicide with a firearm, we would never have the opportunity to meet them in most cases. And that's because attempting suicide with a firearm, again, unlike with pills or other overdoses where the case fatality rate is 2%, attempts with a firearm are fatal closer to 90% of the time. This was 84% based on data a couple years ago. A more recent study actually puts that right at 90%. And I think another kind of common myth out there is that, people just attempt again. And I think it's really an important piece as we're thinking about the being explicit about the messaging, is that more than 9 out of 10 people who survive a serious suicide attempt do not go on to die from suicide. So really, this is not about postponing the inevitable, but if we can change people's access to lethal means in that moment of crisis, it really is an opportunity to save lives. And I think that that's really a profound and important thing to consider as we consider what our approach is in the broader healthcare system. More data sort of in this space showing this sort of these causal links. This is a paper that was published in the New England Journal just a few months ago, that was looking in California. So it's a state with a mandatory 10-day waiting period from the time that a firearm is purchased to the time that the new owner can pick up can actually have that weapon in their possession. And these investigators linked the voter rolls in California to new gun purchases, and basically compared new gun purchasers. So those are handgun owners, new handgun owners in that solid line, and handgun non-owners in the dashed line. And as you can see at the top, the y-axis here is the death from suicide by firearm. And over that 10-day period, so presumably that time where there is no weapon in that person's possession, those overlap. But really starting at day 11 is when you see a real separation. And there have been a lot of studies, the 16 I showed you in that meta-analysis that showed access to firearm as an independent risk factor for suicide. This is by far the biggest, and one of, I think, the most interesting, showing that sort of time-varying risk. A really acute, immediate risk that is sustained over time, but really that acute risk. And I think it's important as conversations about guns really get so politicized so quickly, to just make the explicit comment that it's about any highly lethal means. And in the US, that happens to be firearms, or that is firearms, but any highly lethal means will follow this sort of same arc. And this is a study. There's a group at the Harvard School of Public Health that have really been leaders in this space over years, David Hemingway being one of them. This is one of his favorite examples that he has shared with me that I found really compelling. That Sri Lanka in the 80s and 90s had one of the highest suicide rates in the world. And the most common method of the most common means utilized in these fatal attempts were ingestion of toxic pesticides. And in the mid-90s, it was in 1994, the government in that country banned importation of the most toxic forms of pesticides. And over the next decade, banning those most toxic pesticides was associated with a 50% reduction in mortality from suicide. I'm aware of all the problems in sort of an ecologic analysis like this, but this really was a pretty good attempt to control for a lot of other financial stress, other related factors in the region. But also even more than that, the most compelling thing to me that make me really think that this is a real causal link is that the number of ingestions didn't change during that period. It's just that that exact same behavior became a lot less lethal. And I think as we think about that and the relationship of that to other highly lethal means, I think there's a lot of relevance to it. My light background here. One thing that's really critical is, again, this conversation often talks about gun violence or even suicide as if it's one thing to all people. When different populations are affected, I think the interventions are very likely to be different. And for me, I focus a lot of the work that I do on older adults. And I really started doing that as soon as I started looking at the data and recognizing where some of the issues were. I don't think it's a surprise to this audience that older adult men specifically have the highest rates of firearm suicide in the country. But this figure really demonstrates that it increases at every age group. So you're seeing here 5-year age groups 65 to 69, and then 5-year age groups to 85 and older. The blue bars represent firearm suicide rates, and the orange bar represents non-firearm suicide rates. So those rates of suicide among older adults are really here driven by firearm suicide. And as you can see, these dashed lines, these represent the firearm suicide and non-firearm suicide rates nationally across all age groups. And non-firearm suicide for older adults is actually are right at or below that mean. But really it's firearm suicide that it's way above. And what's driving that? As somebody, I care for a lot of older adults and thinking really specifically and mechanistically, what is driving suicidal ideation and suicide attempts among older adults? And if we think the measure of a society is how we care for older adults or the most vulnerable, I think that's just a question that we really need to wrestle with. And there are many who have spent good parts of their careers doing just that. Social isolation, which apparently you're going to be talking a lot more in September during the first grand rounds of next academic year, is one factor. This is a paper from Alex Tsai and colleagues that was published in the Annals a couple of years ago, where they looked at the cumulative incidence of suicide mortality and came up with this social integration score. And basically with 4 being the least or 1 being the most isolated and 4 being the most connected. And really you can see sort of a stepwise increase, sort of a dose dependence, if you will, that the more isolated that somebody was thought to be by this composite score, the higher their cumulative incidence of suicide mortality was. And, is that a marker? Is that causal in and of itself? I think there are so many other factors here, especially among older adults, to consider. Is it financial insecurity and fear at that stage? Is it pain? Is it chronic undertreated pain? Is it acute pain? Is it depression or other mental health condition? Some of my other work is in the pharmacoepidemiology space, so I pay a lot of attention to issues of polypharmacy with particular high-risk meds, for example, benzos or opioids, but many others. Is it prior delirium? Is it cognitive impairment and dementia? Is it the early impulsivity that's associated with dementia that may be more at risk here? And that's something I spend a lot of my time and recent work really focused on. Is it medical comorbidity? Are people getting devastating diagnoses of cancer, for example, that's leading to these decisions? And if so, is that based on an accurate understanding of prognosis or fear and an inaccurate understanding of prognosis? Because I think every time we've looked, we recognize that clinicians aren't always great at sharing that information, or patients don't always hear what we think we've said. And I think it's especially important to consider in this population. And these are just a wide range of factors based on the literature, based on my own thoughts and our group's work, but really suggesting that some measure of these factors or others may lead to suicidal ideation. Some factors may lead to whether or not some of those people with suicidal ideation actually make a suicide attempt or actually attempt suicide. And then whether or not that person had access to lethal means is going to determine, as we were just talking about, whether or not that person lives or dies, whether or not that's a death from suicide, or whether or not that person is admitted to a hospital or elsewhere. And we have an opportunity to really think about these multifactorial causes and potentially consider possible interventions. And as we do that, especially in older adults, I think I'm particularly struck in how little as internists who care for older adults as the bread and butter and foundation of what we do, how little this is discussed in any way. We're working with visiting nurses in Vermont and New Hampshire, for example, to think about what it would look like to discuss and incorporate questions about firearm safety and gun access into just standard home safety assessments. We are sending visiting nurses into people's homes all day, every day across this country to do home safety assessments. And we're thinking about many things that put older adults at risk. And we're not really asking any questions about whether there are guns at home. And again, just real potential opportunities and misses. Another population that I think we do recognize is at increased risk is our veterans. In 2017, it was an average of 17 veterans died every single day from suicide, and you can see that breakdown by age here. The VA actually, who's been doing a lot of some work in this space. The VA is one of the only organizations that has a specific guideline recommendation for people who are new diagnoses of dementia and cognitive impairment to specifically address firearm access and firearm safety. I think that's a real potential opportunity to think about what the outcomes of those conversations and that counseling have been, and think about how to improve it, iterate, build on it, and really incorporate that much more broadly in different populations. And the truth is, as I said, this isn't incorporated anywhere. So we just said, maybe we don't need to know it. We don't need to learn how to do it. Maybe we are just doing this already. And every way that we looked, we are really, really not good at this. This is a study led by Dr. Caitlin Lee, who's a fellow who works in our center, who basically did a really thorough, detailed chart review and looking at every. She's a pediatrician, and did a detailed look at everybody coming into our pediatric emergency department with active homicidal or suicidal ideation. So this was not all comers. This is a group of people that everybody would consider being at high risk, actively a section for active suicidal or homicidal ideation in our emergency department. And she said in 1 year of those cases, we had 98. How often did a trainee, did a pediatric resident, a trainee who saw that patient, how many times in their note did they mention anything about firearms? And of those 98 cases, it was 5% of the time that a pediatric trainee mentioned something about firearms or document any conversation about firearms in their note. In a little over 2/3 of cases, somebody did during the hospitalization. The vast majority of times that was from our psychiatry colleagues. But that still meant in more than 1/4 of cases, when these are adolescents who are coming in with active homicidal or suicidal ideation, there was no documentation in the medical record about a discussion about gun access or firearm safety. And in some cases, as would not be surprising, some of these adolescents were discharged home without that question ever being asked or addressed. And for me as a general internist, that's like somebody's coming into the hospital with a heart attack and we don't ask them if they smoke. I mean, it's one of the #1 most modifiable risk factors for death from what we know that person has. And that just really needs to be a never event. And we said, okay, maybe we're not doing it there, but maybe we're doing it across other departments in a different way. So we developed a lot of natural language processing and other algorithms to think about how we can track this over time and really understand our starting point. So this is a look at 80,000 consecutive hospitalizations across not only Mass General, but the Brigham as well by department. And we used alcohol and tobacco conversations as sort of positive controls here and just said, how often does some mention of these factors, alcohol, tobacco, or firearms, come up in the medical record? And in alcohol, it was about an average of about 2/3 of cases at some point during the hospitalization was that mentioned. Tobacco came up in a little more than half. And firearms were just a paltry less than, I think, 0.5% of the time. So it's that blue bar here, if you can see it. Our psychiatry colleagues asked more than any others, but still a pretty low rate. So I don't know what the actual right level should be here, whether or not this is a conversation that's, everybody needs to have it at all times or should be more incorporated here. But I think this type of difference here really shows how it is not in any person's automated template. It's not in the way that anybody has really been taught to approach this. And we did a lot of focus groups. We met with a lot of trainees and attendings and nurses and others across our hospital and others. And the answers we got for why people weren't talking about guns with patients ever were, it wasn't rocket science. People didn't talk about firearms because they were never told to talk about firearms. They had no idea what to say. And most concerning to most people was if they asked the question, is there access to a firearm at home? And somebody said yes, they had no idea what to do next. And as we were doing those focus groups and learning those reasons and really hearing them from people on the ground, it just struck us that those are very, very solvable problems, that some information could be very empowering there. So we developed a training program to address this. We developed this novel simulation-based program. We developed this novel simulation-based program. I was getting distracted by a Q&A that happens, where we brought in trainees and attendings from across departments in the hospital. You can see that the 6 that were part of our original case development core here. Let me just say, whatever work that you're doing, if you have a chance to bring medicine and psychiatry colleagues together with your surgeons, I just highly recommend that you take it. You just learn a ton of great stuff. For us in medicine and psychiatry, our trainees and our attendings were absolutely open to this, very willing to incorporate some of these conversations, thought it would take about 20 minutes. Our surgery colleagues were right there as long as they could do it in the time it took to do an abdominal exam. They were right in there. It was just a lot of great back and forth by putting colleagues across different departments in a room together. And what we did was we developed cases that had some core foundations that were similar, but were really tailored to each department's sort of own clinical experience and clinical context. And then we hired an army of standardized patients, of patient actors, to come in and work through these scenarios, from the most basic, just routine conversations about screening for firearms and other weapons, to more complicated conversations that people were worried about would happen. And this has grown. This program is now part of our medical school training curriculum, is a part of intern orientation across departments. COVID-19, of course, introduced a challenge of making parts of it virtual, which we're also looking into. But what we saw by and large was that almost all of our incoming trainees really thought that this was important, and people really just a training session on this, a 90-minute training session, really improved people's comfort in having these conversations, because the vast majority had not, up until that point of day one of intern year across departments, the vast majority of people who have taken part in this program had no prior training in this area. And so what do we teach during this? We talk about some of the basics. When talking about firearms, focus on health and use a non-judgmental approach. We let people sort of workshop their language around that and give specific examples. One of them, because there are risks to having a gun in the home, I ask all my patients about gun access and safe storage. We really get at that question that people were most concerned about, is if somebody says yes, what are the next questions? That's really answerable. Here is just one method. What is referred to as sort of the 5 L's of follow-up questions. If there's access to a firearm at home, is it locked? Is it loaded? Are there little children present? Anyone at home feeling low? Sort of getting at that link and getting people to think about that link between suicide and firearm access. And this last L may be a little stretch. Learned, is everyone at home learned or been educated about firearm safety in some way? And then we have resources to offer sort of at that point of care, whether it's firearm training courses, gun locks, which I'll talk more about, but just information there. Making it very clear to our clinicians that the answer isn't that you have to know everything about this topic or develop this expertise, but you have to be able to take that one next step and know who your resources in social work or others are to call if you do have questions. Another piece that we talk about are extreme risk protection orders. Massachusetts passed one in 2018. New York passed a red flag law in 2019. These are different in every state. The stipulations of who can file these are different in every state, but the many states that now have them offer some legal pathway with due process well intact to remove firearms from homes of people who might be an imminent risk to themselves or others. And really, again, this is not designed in some of our early sessions to make sure that everybody's a legal scholar and knowing the ins and outs and able to answer every due process related question, but really to recognize and be aware that these exist, so that if a clinical conversation comes up where maybe this is relevant, they know that there's something to look for, or know that the specific question to ask our social workers or others around the hospital who know these in detail. So happy to answer more questions about that specifically. The other message I think we convey to anybody going through sort of our courses that we run, but really just everybody, is that this us versus them mentality of gun owners versus not is something that we really can't afford to perpetuate. And it was more than a third of households across the country. There's a gun in more than a third of households. So this idea that it's just some rare minority, it's just absolutely not the case. For us in Massachusetts, the gun ownership prevalence is, depending on where in the state, about 10 to 15%. That's lower than the national average, but that's still the same prevalence of smoking across Massachusetts. I don't think anybody would say smoking is so rare we should stop asking our patients about it. We have a lot of patients, for example, in Massachusetts that come see us from New Hampshire with a much higher gun ownership rate. And that's just something to recognize and be aware of wherever you practice. There's a group at the Harvard School of Public Health that I mentioned before, and we'll emphasize again, that do a lot of great work and really getting at this point in particular. But they do a lot of work with gun shop owners and bringing some suicide prevention education and modules and trainings to gun shop owners themselves, who by and large are the last people that would ever want to sell a firearm to somebody who's going to use it to hurt themselves or others. And in many cases, finding people who are gun owners and respected in that community as trusted voices may be better messengers for that same message than a doctor in a clinic. And I think being open to sort of anybody who's willing to further that goal of harm reduction and education is an important one. So here's just sort of a list of different places across so-called red states and blue where there's work really being done here to think about issues at the point of care, which those data I shared from the New England Journal publication last year may suggest that people are really walking in with suicidal intent for new gun purchases in some minority of cases, that it's actually even more important to think about the point of sale as a potential opportunity for intervention. So as we switch gears, a little bit to talking about homicide, and other interpersonal violence. I think it's important to recognize that sort of disrupting cycles of violence here are really critical. And important to recognize that certain populations are at increased risk of gun violence. For example, women experiencing intimate partner violence are 5 to 10 times more likely to end up dead, to be killed, if there's a gun in the home where that violence is occurring. Important to recognize this is true in cities across the country, and that gun violence disproportionately affects communities of color. And I think what's really important to recognize, unlike when we're talking about suicide, in which we were just saying that 90% of people who attempt suicide with a firearm end up dead, the vast majority of people who are shot, not in a suicidal context, the vast majority, or at least 3/4 or more, survive. And therefore, when we're thinking about it in that way, focusing on gun deaths really underestimates the toll of gun violence. The deaths, which is the number that we focus on nationally or we discuss, is really just the top of the pyramid here. That there are all of these non-fatal injuries and people who survive and maybe become our lifelong patients. There's the trauma that's associated when shots are fired in communities, and it doesn't have to hit somebody to cause trauma. A gun actually can be used in threats, doesn't even have to be fired to be threatening. And then really underlying that is really the community and individual perception or fear of the impact of gun violence or its potential impact in their lives. And I think that's really important to recognize, because in contrast to precise tracking of fatalities, data on non-fatal firearm-related injuries are really limited. This is a literal screenshot of my attempts a couple of years ago to build some tracking modules of non-fatal injuries. This is directly from the CDC website. All of those data that I shared earlier and figures I had made come from CDC fatal injury data, which have been validated, are reliable, are really spot on. And the CDC was doing the same thing for non-fatal injuries. And you could look them up in the same way. It looked all official, like this screenshot here. And this shot, when you look it up, looks like in 2017, there were 133,895 non-fatal firearm-related injuries across the US. And if you happen to notice the two asterisks sitting next to it, is the CDC's way of calling that an unstable estimate. And when you look at the confidence interval associated with that estimate from CDC, they say it's somewhere between 30,000 and 236,000 non-fatal firearm injuries. A lack of precision, a number that's just so imprecise, as I would say, to be entirely useless if you're trying to use these data to really track, to understand the scope of the problem, to track prevention efforts. These data are bad data are really worse than no data. And CDC, to its credit, recognized that shortly after and suppressed these numbers. So you actually can't go and look these non-fatal numbers up anymore on the CDC website. And all of that, these estimates, which were growing for more than a decade, more imprecise by the year, was really related to the sort of the tracking efforts that CDC at the time that it was doing this was using, I think, a dozen hospitals and what we were seeing there and extrapolating those across the country. So really not a reliable way at all. So it's a step forward, I guess, that these numbers are now suppressed and we don't even pretend to have access to bad data. But we really need to invest in that infrastructure if we're going to really understand parts of this problem and think about how to prevent it. This is some work that came looking at New York State specifically, and that's because New York State leads the way, is better than a lot of others. California has good similar infrastructure. Massachusetts does not, by which all hospitals report in a way that makes this evaluable. And when we did this analysis looking at New York State hospitals across the country, we saw that non-fatal firearm-related injuries really disproportionately affect communities of color. You see the rates here. These are annual incidents over years from 2005 to 2015, annual incidence rates of non-fatal, again, firearm-related injuries. And we just see that the impact on communities of color here among our Black patients and are really much higher than any other group. And again, I don't think this is calling out New York specifically. I think it's an opportunity that New York has to look at these data because they're being collected in some real way. But I think this bears out critical trends that we're seeing in a lot of places. And it's true in New York, and it's true in Boston, right here, which is considered often one of the safest cities and one of the safest states when it comes to gun violence. A couple of years ago, I was at this event hosted by WBUR Public Radio at BU. And it was this 2-hour event, and it was like the who's who of Boston politics talking about gun violence prevention. And it was Governor Charlie Baker was there, Attorney General Maura Healey was there, Speaker of the House at the time, Bob DeLeo, sitting right there, was on this panel. And it was this 2-hour panel. And the first hour was every panelist saying some iteration of Massachusetts is the best. Massachusetts is great. Boston is the best. If every other state did what Boston does every year, we would save 25 or 30,000 lives from gun violence every year. Massachusetts is great. Boston is great. And that went on for about an hour. And this woman right here, her name is Monica Kanan Grant, and she was not invited. She was not on the panel originally, I will tell you, but she stood up in the back of the room and she said, she took a mic and said, I have let you all go on for an hour, but the Boston that you're talking about has nothing to do with the Boston where my kids and I grow up. And she had brought in with her 10 young students, all young people of color, and gave them the mic one at a time. And God bless them, they did not give it back, as each one of them just told us specific stories about how gun violence affected their lives personally. Family members, adults in their lives who had been shot, had been injured or killed. One student told a story of having to walk past this car that's been riddled with bullets every day and what that does to her as she's walking to school. Other students talked about having to take the long way home to avoid violence. And that's in one of the safest cities that, if you look at national stats everywhere, Boston will do pretty well in terms of violence and in terms of gun violence in a city. And here was groups of students just saying that that was not their experience. And I think that really shows in so many ways, one, the importance of making sure that we all use the platforms that we have to include the voices of people that are most affected by the issues that we're discussing. And really this critical miss that we're going to have if deaths is where we stop, that there's so much else below that tip of the iceberg that we really need to think about when we're thinking about the impact of gun violence on our communities. And I think it's just important to recognize that I could have given that, that part of this talk 18 months ago, but how is COVID really changing this national landscape? We talked about the increase in shootings in most cities across the US over the last year, but we're seeing a lot more gun sales. So this is an analysis done by the New York Times looking at gun sales in the country, showing that March 2020, as sort of lockdown orders were beginning, about almost 2 million guns were sold, and that was the second most in the history of in the decade since we've been tracking these types of data. It was the second most. The only time that had that month beat was the month after the Sandy Hook shooting and Obama's reelection. And one of the most striking things, and these numbers stayed high, this wasn't just a one-off high in March 2020, these numbers stayed high all through the year, is that by and large, up until this point, when people were buying guns, it was gun owners that were buying more guns. What we think we've seen through some preliminary data, and again, we're going to need to see if this really bears out, but there was a big increase among first-time gun owners and more new gun owners. And I think that there are potential implications and ramifications of that in a time with really unprecedented isolation and financial strain and stress that has been unpredictable in many ways over the past year and beyond. I do also want to mention, and again, I will take any opportunity that I can to move this conversation away from the hyper partisan or the political. Just mention here that it's about 4.6 million kids in this country are living in homes with unlocked and loaded guns. And I think whatever people's politics are, we agree that that number should be zero. And that's the mechanism to preventing this 2% of shootings that we're seeing of these unintentional injuries. And when we think about mechanisms to maybe get at that, if these guns are being stored unsafely, maybe we can offer some help to help store them more safely. Here's just an example of what lives on sort of our own intranet here that clinicians have access to all the time. Information to give patients about different gun lock storage options and their cost. We make gun locks available for free in a lot of our clinical sites. So in our primary care clinics, these sit next to the condoms and the bike helmets of, all the other things that are in our harm reduction arsenal that we just offer patients at that time. Certainly in the pre-COVID period where there were more sort of community fairs and health fairs and all of that, we would show up with gun locks. The number of times people say, no, I don't have a gun at home, but can I please have a gun lock? No questions asked. We are happy to have those just sort of disappear. It's one small thing, but it is something. And I think it helps in two ways. One, it is a literal concrete tool that we can offer to our patients, but also clinicians are humans and I think are much more likely to ask a question if they have swag to hand out or something to do. It's a disarming answer to the question. If you ask the question if there's access to a firearm and the patient says, why do you want to know that? And it's a simple answer, because I have free gun locks available here that I'd be happy to offer if that's useful to you. is just a way to, if you feel that temperature escalating, to really de-escalate it. And it's, again, just one more way to make it part of the culture of what we do here across the hospital. And I think I want to come back and sort of end this part of this conversation where we started, about mass shootings as a small fraction of the problem, but really a dominating force in the national discourse. And I think that that's not just taking away the energy from places where maybe we could have more of an impact, but it really does start us down a solution-oriented path that may be taking us in the wrong direction. One example of that I wanted to just mention is the tourniquet training programs are really gaining ground. These are led, the Department of Health and Human Services had a partnership with the American College of Surgeons. I work very closely with a lot of surgeons on a tourniquet training program, including for high school students. So a couple $1 million at a time when very little federal funding was going to gun violence prevention efforts. In 2018, for example, Homeland Security gave out a couple $1 million. This is, the own description. This isn't mine. School-age trauma training grant aims to train teens on how to assist victims with traumatic injuries in emergency situations before responders arrive. And I think, as these programs proliferate and you can see the number of people and young people who are being trained to use tourniquets, I just think there's a, I don't want to be the anti-tourniquet person. I think that maybe there is a time and a place, but I do think that we need to think about the potential cost here of turning all young people into mass casualty responders. And maybe some amount of that training is empowering, but I think we really do need to grapple with the extent to which it may be traumatizing. And I think even maybe more specifically to the point of what we're trying to do is, would it even be effective? When we're talking about a tourniquet as a solution to gun violence problems nationally, I mean, what percentage of injuries are even tourniquetable? So you're talking, in order for this to be relevant, you'd have to be talking about pretty much an isolated vascular extremity wound. And this is where I'm very grateful to be part of a multidisciplinary center. We work with a lot of trauma surgeons, and we sort of delved into that literature and looked over a couple of years of data and said, when people come in with these injuries, what percentage of gunshot wounds are vascular extremity wounds? And we found that it was 1.7% of those injuries. So to be sort of mobilizing a very large federal program that could at best target 1.7% of these injuries, and again, extrapolating blast injury data from the combat setting as if that's directly applicable to the gunshot wounds, I think there's a lot of big leaps there, and maybe other ways that those resources could be more effective. Another thing I think worth discussing about what I don't think will work. I promised you I would tell you when I'm speaking well-grounded in data. Here's a place where I am not, because there aren't a lot of data on this, but active shooter drills are proliferating across the country. More than 90% of all public schools now have active shooter trainings, more than 90%. And I bring that up as just a staggering number. If you were to try to promote uptake of anything across the entire national public school system and get uptake of 90%, you would think of that as a huge success. And the place that we've done that is for active shooter drills. This is a proliferating industry now. This is one of several training programs that are out there and offered. But I will say I'm not aware of any evidence that if hell were to come to a particular school or office that day, that having trained all of the sort of civilians or students or anybody there will alter that outcome. And I think, again, before we're turning every K through 12 school, healthcare institution, higher education, business and government building, and everybody who works there into mass casualty responders, I think we need to really think about the potential costs there that we'd be seeing. In order to do that, in order to fund this work and answer some of these questions, which I hope if I've conveyed something is that a lot of these questions are answerable. And research here does offer us a path forward to thinking about harm reduction techniques, to think about these methods, to think about what's effective counseling and what isn't, to think about where that's effective. We're going to need money and we're going to need grants to study it. And it's not going to surprise anybody to make a statement that NIH dollars are not necessarily awarded in proportion to morbidity. But this is a pretty striking analysis put together by a group at the University of Chicago a bunch of years ago, looking at data over 40 years of the total number of cases of certain diseases, and then the NIH research awards that were awarded. So for the 400 cases of cholera in the US during that period, 212 NIH research awards were granted. For the greater than 4 million firearm-related injuries they came up with, it was 3 during that period of time. And again, this is not a zero-sum game. I'm not advocating to take money from collar research and give it to firearms. A group more recently sort of did this in a even more systematic way, looking at the rate of funding for gun violence research compared to other causes of morbidity and mortality, and really showing that by and large, there's a decent relationship there between morbidity and mortality and the NIH dollars spent, but with a couple outliers here, falls being another that NIA has more recently invested a lot into. That gun violence compared, we started this talk talking about liver disease, same number of deaths every year from liver disease and gun violence, but orders of magnitude different in terms of where we put our federal dollars. But I really do think that we're at a turning point. I am very hopeful in this work. I think this is a tough problem, but I think that this is a solvable problem, and there are real opportunities for new investments here. Last year's congressional budget was the first in decades to specifically advocate research dollars in this space. So $25 million to the NIH and CDC. When you think about the pipeline of dollars not spent over decades, that's, you know, maybe a drop in the bucket, but it's an important start. Our center was among, I'm sure, many others who submitted grants to this first ever, or first in decades, gun violence specific RFA that was out last month. So I really think that there's a lot of reasons to be hopeful and to really think about this issue like we have been taught as clinicians and investigators, with that hat on instead of sort of the hyper-partisan one that too often I think wins the day. So I am so grateful for the invitation from Dr. Posner for being here, and I can't see any of you, so I assume you paid attention, but it was really great to be here, and I'd be happy to take any questions.
Thank you so much, Dr. Sacks. That was really an extraordinary talk and presentation. And you know, the topic is of such national importance for all the reasons that you described, and it's also one that, as you indicated, can be difficult to delve into and becomes politicized very, very quickly. But I think if there is a path forward, it's going to be from health professionals, particularly people like internists like yourself, who can talk about this in a very even-handed, level-headed way that's really puts the data first. So thank you so much for presenting to us and for the work that you're doing.
Thanks for having me.
So I guess I'll get us, there's a bunch of questions coming in, but I'll get us started with the first question. So throughout your talk, you alluded to the issue of funding around gun violence. And you know, there's as far as I understand, there's a fairly long and somewhat complicated history about the federal government's response to gun violence and research funding around that. I was wondering if you could outline that for us a bit and tell us sort of where things got derailed and how they're, at the end, you did allude to how they're improving, but it'd be great to hear some more about that.
Yeah, absolutely. And I think this is a critical question, and some misperceptions about this question I think are important to just shine some light on. So what people are referring to when they think about the ban federally on studying gun violence is what's the so-called Dicky Amendment, which I just want to be very clear was passed in the mid-90s, and it's not an outright ban. It was language that a Congressman, Jay Dickey, put into a budget appropriation bill that then got passed every year and later at the NIH, the language of which literally said that no federal dollars could be used to, quote, advocate or promote gun control. That's the language. That's what was in the budget appropriation. That's what's there every year. Interpret that as you will. So, you know, I say that to say it's not an outright ban that federal dollars can't be used to say that. I will say it was interpreted across federal funders and many people seeking federal funding as sort of a literal shot across the bow, if you will, that this is an area that you should steer away from. And I think that type of language is actually more insidious in some ways than an outright ban. And I say that because a ban can be overturned. What we saw over the last bunch of years is people were advocating to like overturn the ban, and then people were rightly saying there actually is no ban. So it was clarifying language that needed to be issued. And that's really sort of the way this has gone down. Maybe worth saying that, you know, just because it's quite a story. Jay Dickey was the congressman who really made that push for it originally. Mark Rosenberg at the time was head of the part of CDC that was running this. He eventually was fired for continuing in this line of work. those two then became like fast friends. They wrote a Washington Post op-ed a bunch of years ago before Congressman Dickey's death together, talking about how Jay Dickey himself talking about the total ban on funding needs to go and is not what was intended by that initial language. And even if it sort of was the intent of the initial language, is not what he meant by it in that day. So I will say that even the person who put that language in does not think of it as an outright ban. There's no outright ban, and more money, though, needs to be specifically targeted to it. Where I really started to change my tune, though, and my approach was there was so much energy in the medical community of there's this ban and we can't study this issue because of it. I went back to the federal budgets and I looked at it. Of the year before that ban was put in, it was a couple of $1 million a year that was being awarded. When you're working in an organization like Harvard Medical School, Mass General, Columbia, and you're looking at the grants that our colleagues are sort of pulling in, and you realize that it was a total of a couple $1 million across the country, it was just a real alarm bell in my mind that said this isn't necessarily the only path here, that we can go out and raise a ton of money and try to use the philanthropy that a lot of people are better than I am at raising, and really sort of try to build a research nest egg here and get to work. And by and large, that's some of what we did. We got that seed money that really helped us build some of this program, and already for us generated a lot of the preliminary data that can then be used in sort of other scale grants. And my hope is in more NIH, and my hope really soon to come is CDC reinvestment in this space, which is I think a real opportunity here, and leadership there that makes me think that's a real opportunity.
Great. Terrific. So Ralph Wharton writes in asking about the epidemic of violence, and if it is an epidemic, should we think about it as contagious, and what are the implications of that?
I think that's a really, really excellent question. There's been some work looking at sort of geocoding, exactly just like you're saying, how violence perpetuates. It's why I sort of talked about those cycles of violence and how do you interrupt. I didn't refer to it as a transmission chain, but maybe. And really thinking about that. Violence intervention programs, thinking about what resources we wrap around people who come into the hospital with these injuries when we send them out, I think is a critical place that some places are much better than others. Boston Medical Center, for example, has a violence intervention advocacy program that really, that we have one too, and I've learned a ton from them, though, that we sort of wrap these resources around people to try to help deal with some of those root causes and use that hospitalization as an opportunity to disrupt some of those forces, to get people back into school or job training or CV help, all of those many multifactorial pieces of what led to that injury. How do we address them in a better way than what's been the medical standard of care for decades, which is we get good and even better at fixing those injuries and sewing them up and sending people out. And how do we really think about it in that way, I think is a great point.
Great. Luis Lopez writes in, thank you for this presentation. And he notes that gun ownership perhaps should not only be thought of as a personal choice, but part of a specific American tradition, and asks whether medical professionals should engage in that narrative and potentially try to change that narrative.
I think it's so important. And I think that's part of why I try to take that approach. You can't not acknowledge that, right? I can't walk in here and be like, this is not a controversial issue at all, no worries. But I think some of the issues when you're thinking about what it really means to bring violence prevention or suicide prevention to the bedside, when I'm talking to an older adult patient who family is sitting all in there in the visit and they've come because they've noticed, memory concerns, and that's the focus of the conversation is kind of this subacute decline, and somebody's living at home and has always been independent. A conversation then about whether there are guns at home, it's not about whether or not that person has the right to that weapon. It's a conversation about what is a relevant safety question, the same way we talk about driving, the same way we talk about, in the most concrete ways, we talk about shower bars and tacking down rugs at home. The way we talk about just optimizing home safety, it becomes part of that conversation. And I bring up that point because it's something that we don't know. I showed you some data suggesting that when people die from firearm suicide, they are newly purchasing guns with probably some suicidal intent. I think that's probably different for older adults, but we don't know that. I would bet you that the firearms used among older adult suicides have been in the home for decades or longer, but nobody really thought about it as a risk as somebody gets older. When you make the conversations about issues like that, when you make the conversations of I'm not even engaging on that question of like, do you have a right to? It's just I'm offering you a free gun lock if you want to, or information on those other pieces. When you approach it in that way, I think that maybe it's an opportunity to sort of reframe that conversation, not to ignore the highly personal or politicized nature, but how to make it more medical, and whether it's vaccines, whether it's, I think there's a lot of issues like that we're trying to depoliticize, and a lot depends on whether or not we can figure out how to succeed.
Great. Yuval Naria writes in with two questions. So first, can you discuss what's known about risk of gun violence among veterans in general, relative to veterans with mental health problems such as PTSD? And then second, can you talk about what's known about interventions among gun owners who suffer from mental health problems such as depression?
I think that this is a space where we have so much more work to do. And I think, the VA has been a real leading force here, recognizing, so just some of the baseline rates, I showed one slide of it, but I could show infinite numbers. Veterans across the age spectrum are at increased risks of suicide, and it's not even close. It is a markedly increased risk. And I think, what's almost most striking to me about that slide there was sort of a really significant, it's not that low of a tail of older adult veterans. And those are people who survived wars decades and decades ago, survived that trauma, survived the substance use epidemic that took the lives of many of those that served with them. And then something is happening when they're older adults that leads to death this way. So I think that there's a lot of different pieces, and among veterans, again, are we talking about veterans over the last 10 years in the wars of the last decades? Are we talking about veterans from older wars from decades ago? I actually think those are probably some different issues, some similar, but some different. But I think really one of the keys that we see in the other population, we see a lot of high rates of suicide are police officers, and it really tracks to who has guns around in high numbers. And I think that really is one of the differences, that it's a population with, yes, a lot of trauma and PTSD and depression potentially, but really a lot of access to guns that makes that moment of stress or moment of impulsivity or moment of crisis a lot more lethal. So the VA is doing a lot of work to get to your specific questions. How do we move this from the sort of epi phase to the intervention phase, which is the critical, I think, the critical direction here. A lot of work on this idea of temporarily removing firearms from homes during periods of crisis. Red flag laws offer sort of a last pathway of a legal resort, but how do you create sort of culture change, which is something the VA and other veterans organizations are working on to sort of change the narrative, the way that, friends don't let friends drive drunk. Friends don't let friends going through a bad patch have a gun at home. And that's sort of another David Hemingway-ism of how do we just sort of change that culture to not this taboo topic that we can't talk about because it's infringing on rights, but really the definition of what it means to talk about putting your friend's well-being at the center of the conversation. And guns are just inextricably linked with that in that population, but in many others too.
So another listener wrote in with a question about your training programs and asked whether you distinguish specifically about asking about firearms versus access to weapons more generally.
Yeah, I think that's a good question. I mean, when we're talking about suicide prevention, the focus is generally a little bit more on guns. We don't have a specific part in that curriculum talking about knives, for example, or most other weapons. But it is why I brought up the pesticide example, is that we're talking about any highly lethal means. And this is one inroad to have that conversation. It's one that people are sort of most afraid of bringing up. So, I think firearms has been one of the specific focuses there, but the same way we talk about, pills and other things at home and keeping those locked safely from little kids. And I think, not to define a pill as a weapon, but in the wrong hands, it could be.
Steve Heiler writes in asking whether insurance companies such as health insurance, life insurance, disability insurance ask about gun ownership, and if they don't, why not?
Yeah, it's a really, really good question. And to my knowledge, and we looked at this in a lot of depth not so long ago, so I don't know if there were more recent changes. It's typically not a question that has been that insurers have used to stratify rates or anything else. I'm not sure that's where I'm spending my specific time, is getting those insurance companies to change that. Part of it may have to do with where and to whom the injury occurs, and on site that, pools have a higher risk, for example, of somebody coming in and having a fatal event there. But I think there's a lot of analogies, and there are groups pushing for just that.
So another question is whether either the Veterans Association or the Department of Defense could be doing more toward limiting guns. For example, at the time of discharge from active service, require an inventory of mental health at the time of discharge.
I think that's a really, really good question. I think we need all hands on deck here, and I think that's absolutely an important question of who gets their weapons with them. Police officers take their, oftentimes take weapons home at night, and police officers, as I mentioned, have high rates of suicide. So I think really all hands on deck need to be there to deal with this, to confront this problem and think about it in creative ways. And I think that's another opportunity, I think, to break down some of the common barriers that we see, that if it's the DoD, if it's police officer unions that are starting to step up and take the leadership on talking about this as a problem, because it's a problem for the people that they are representing, I think it'll go such a long way to break down this barrier of gun owner versus not gun owner. And I think that's really, really critical. I think there's maybe also opportunity for, in tech innovation, that for people who are buying guns because they're trying to, quote, protect their home, what are, non-lethal weapon options that we have out there? And how do we even think about that? So that if somebody thinks they're shooting an intruder and God forbid shoots their neighbor with dementia who had wandered into the wrong home, how do we make it so that that person, wakes up days later with, wakes up a few hours later with a headache instead of, the experience that's just all too common that people have killed their neighbor. So I think there's a lot of opportunity for outside the box thinking and innovation here that we're just sort of scratching the surface of. And I think every partner that you've mentioned will be critical in doing that.
So it sounds like this may be what you're aiming for in your training program, but William Tucker asked whether any residency programs in any specialty prepare trainees to inquire routinely about the presence of firearms in the home and the degree of access to them in the course of initial healthcare screenings.
Yeah, very little systematically. And like I said, when we were sort of doing these surveys among programs that exist out there, psychiatry programs sort of were one of the few that had at all some lethal means counseling or some risk stratification suicide discussions early on. And maybe that's clear why, but hopefully I've made the case of why I think it needs to be much broader. But no, by and large, not that we found. Some are doing their own, I think a lot of these programs have been building one off. There's a lot of work that we're doing to unite with other programs to sort of make either what we're doing, we're making all of our educational stuff readily, freely available to anybody who wants it. We're thinking about a lot of ways of how do you scale it better? Can we do these, it is labor and cost intensive to have patient actors sitting there. Can it be incorporated into other parts of training where patient actors are already being used, or can we find some other tech avatar based, for example, solutions to this that other programs that we're working with other programs on sort of developing. But I think we're gonna have to try this and do it. I don't see this as it's not systematically a part of training really anywhere, from surgical training where we see the injuries to preventative kind of healthcare focused residency programs. It's just really, really uncommon. And we're focusing that. We do it among our residents across the hospital. We're in the medical school. We're in the PA programs at BU, for example. So I think, we're working on sort of citywide how to get this across the medical curriculum as just one tool. But I think we have a long way to go here.
So I think you touched a bit upon this, but David Forrest asked for some more thoughts on the greater fear of crime recently and potentially a defensive increase in gun purchases and how that may have implications for suicide risk.
I think it's going to be a critical thing that we need to look at. There have been some conflicting data on what COVID has done to suicide risks. I'm showing some increases in some spaces, I'm showing not. So I didn't think those data were solid enough to sort of share and make better points of yet. But I think as we collect them over the next year, we'll know part of the answer to that question. I think, like I said, the fact that there seems to be a lot more first-time gun owners here is probably going to affect that in some way. That maybe there's a chance of less knowledge, less experience with guns if you're buying your first gun now in a moment of fear. I think is very real. And then I think, it's people using that security, in an editorial I wrote to that New England Journal article I shared, we referred to Americans buying guns as their own form of PPE in some ways, that there really is that response that people are buying it for thinking that it'll make them safer. And, we have a mountain of data to the contrary, that a gun in the home is more likely to be used against themselves or a family member or a friend than it is against kind of this unknown intruder. But I think that that's a narrative that we're fighting hard against, and we're fighting hard against it by a group that is investing a lot of resources trying to amp up gun sales. And I think that those are just powerful forces that are a powerful financial force that really that makes a lot of money off of convincing people that that's right, and makes a lot of money every time there is one of these horrific national tragedies. And we see gun sales spike after every public mass shooting. And I think that's just, to pretend like we wouldn't have to confront that or deal with that. It is a response that some subset of people think that will make them safer in that moment. And, rather than telling people that that's, wrong or it's how do we do this in a more thoughtful, creative way? How do we think about what training programs actually would look like to make people safer with them at home? How do we think about what background checks would look like, which which are not controversial among all of the US? You only find that controversy if you go into certain state houses, but the populations of those states don't find background checks controversial, for example. So I think there's actually so much more common ground here in areas that we agree. And we need to figure out how to push some of those forward before we take kind of the most controversial and say we're going to start there. There's so many places where I think people really do agree. But this issue does not stand alone when you look at sort of the national discourse and ability to move the policy sphere forward in a rational way. And part of the reasons we started with sort of looking inwards and looking at the training programs in our own hospital in our own city was because of that realization that, when else was I looking to, Mitch McConnell and Nancy Pelosi to solve my problems? The idea that we can't start until the federal government acts, no matter what problem you're looking for, that's probably not a great, a great solution. And how do we think about the solutions that are right here in front of us? And how do we, even if they're not the biggest, the biggest opportunities, even what are the opportunities right in front of us? What are the opportunities that don't involve changing a single law? And for clinicians, I think that's just an interesting thought-provoking place to start.
So Alex Dranowski writes in, do other societies where gun ownership is high and comparable to ours, Canada comes to mind, have similarly high rates of suicide, which then track with access to firearms? If not, then do we have any speculations as to why?
Yeah, I think, the Canadian experience is really illustrative in that way, because Canada has a lot of guns. They have a lot of different kinds of guns. So I think, there are two pieces. One is that handguns are much, much, much more likely to be used for fatal suicides than long guns for, some literal mechanistic practical reasons of turning a long gun on oneself. So Canada has an amazingly deep hunting traditional culture, a lot of long guns in that country, fewer handguns, and it's night and day of what it takes to get a gun in the US versus Canada in terms of background checks, other things that are associated with it, safe storage regulations. It's really sort of night and day in between those two countries. So I think that's another great example to cite, to talk about how nobody's suggesting that we're like getting rid of all guns. Like, that's not what is being discussed on the table, but it's about how do you, there are more guns than people in the US. We just need to acknowledge that in a very open way, that it really is about harm reduction, and how do we learn from other countries like Canada that have a lot of guns but have been able to do it a lot more safely because their rates are much lower than ours.
Wonderful. So I think we'll have to stop there. So again, I really wanted to thank you, Dr. Sacks, for the just terrific work that you're doing. Wonderful presentation. and really providing a model for us all to how to talk about these issues in a way that's effective and really will move the conversation forward. So thank you so much.
My pleasure, and thanks for having me, and please reach out if I can help in any way.
Wonderful. So we will stop there. Thank you everyone for joining us. We will take the month of August off and look forward to seeing everyone again in the fall. Bye-bye.